Good morning, everybody. Welcome to the first of our departmental grand rounds of this decade. So I'm pleased to see you here this morning. We have a great talk ahead of us. After the talk, as usual, after everyone rushes the podium to talk with Jürgen, we're going to sweep them away across the hall to meet with our residents and the trainees around 9:30. And let's start with that theme of trainees. I want to introduce Eric Rafa Yuan, who's our chief resident in the community track, to do the formal introductions.
Good morning, everyone. It's my pleasure to introduce Dr. Jürgen Unitzer. He is the professor and chair in the Department of Psychiatry and Behavioral Sciences at the University of Washington, where he also directs the Garvey Institute for Brain Health Solutions. He trained in medicine at Vanderbilt University and further advanced his education and training with multiple fellowships in geriatric psychiatry and primary psychiatry, as well as a master's degree in public policy and an MPH. With more than 300 scholarly publications and numerous grants, Dr. Unitzer is an internationally recognized health services researcher, with his work focusing on innovative models of integrating general medical and mental health services. He led the development and testing of improving mood, providing access to collaborative treatment or impact model, an evidence-based model of depression care, which form the foundations of the collaborative care models we have today. He has been honored with more awards than I have time to list, so I'll leave it at that for now. Please give a warm welcome to Dr. Jürgen Unitzer.
Thank you. I think I'm wearing one. We should probably turn this guy off. Thank you so much. Can you guys hear me okay?
Yeah.
All right, awesome. Let me see if I can manage the technology here. All right. Okay, so we're in a neuroscience building, and I'm going to say almost absolutely nothing about neuroscience, so I apologize about that just right ahead of time. And if that's what you came here for, I'm not going to be offended if you step out. I'm going to start with a little disclosure. My day job is I chair the Department of Psychiatry at the University of Washington in Seattle. I have some adjunct appointments in our School of Public Health. I still do a fair amount of grant and contract funded work, all with a focus on integrating behavioral health services with the rest of our healthcare. And our healthcare system, I have all of my current and recent funding acknowledged here. I don't think I have anything that creates any significant conflicts with what I'm going to present here today. I'll start by telling you a little bit about where I'm from. I'll tell you a little bit about our organization, which is called UW Medicine. It's a large umbrella organization that operates 8 distinct entities, including a county hospital, a university hospital, 2 community hospitals, a physician's practice plan, a school of medicine, and a company called Airlift Northwest. And the reason we own a fixed and a helicopter wing airlift company is we are the only medical school, allopathic medical school for a 5-state region up in the Pacific Northwest that covers about 27% of the US landmass. So our, what does that mean? We're also the only psychiatry department for that 5-state region. So we're a large department. We have about 1,000 people that work with us. We operate the largest residency program in the United States. And all these little dots you see on this 5-state map are sites where our 3rd-year medical students can do their psychiatry clerkship. So we have a very distributed educational program. Our residents, we have 5 separate matching numbers. We have a Seattle-based track, a research track, just like you guys have, and we have Spokane, Washington-based tracks. We have a Boise, Idaho track. We have a Billings, Montana track. These are all UW residencies, but the residents are working all over the Pacific Northwest. So that makes this a little unique. And the reason I'm saying all of this is the reason why I think we got into thinking, when you don't have access to a psychiatrist in the traditional psychiatric clinic, what do you do? And the vast majority of communities in these 5 Pacific Northwest states will never see a psychiatrist or a psychologist. So that's really the backdrop for why we got, several decades ago, and just not me, people before me got into sort of saying, how do we do how do we reach more people? What kind of approaches do we have to use when you don't have a psychiatrist? All right. So just for those of you who are pure neuroscientists who spend most of your lives thinking about things you can't see with the naked eye, I'm going to do one summary slide about why this stuff that we're dealing with matters. And I think that, we all know this, but what I would say is I've been at, mental health work for a little over almost 3 decades now. And I think the biggest change I see is people are now woken up to the fact that brain health and mental health problems are a huge driver of disability. That was not the case, I think, when I got into this field. So what we know now is that mental illness and addiction problems drive about 25% of all health-related disability. In fact, in this country, there's 5 times more disability caused from mental health conditions than from diabetes or heart disease, and 15 times more disability than what's caused from cancer. Now, you might say, how could this possibly be true? Cancer is a terrible thing. You could die from it. The big difference is cancer comes at most of us in our 60s and 70s and 80s. By the time the people who live with serious mental illnesses, 50% of them will have presented by the time they're 14 years old. 75% will have presented by the time they're 24 years old. And then you're living with that illness for a long, long time. So the cumulative burden from a public health perspective comes from the fact that these problems come at us so early in life. And I think that's something not everybody really fully appreciates, when we're talking to the people who are doing cardiovascular, disease work or cancer work. They can't quite understand that until they have a family member who struggles with this. We also know that these conditions are incredibly expensive. From the perspective of an employer, I think our employers are increasingly recognizing this isn't just something that affects poor people who are homeless on the street. This is something that affects their workforce. In fact, it might be a huge driver of problems in their companies. And so for many years, so we do a lot of work, for example, in Seattle with the Boeing Corporation. Those guys have a very good handle on their employees, when they're at work, when they're not at work, how many mistakes they're making at work. They have very good granular data on this. And they've always understood that when somebody's not doing well and they're not at work, that's called absenteeism. That's a problem because then you have to find somebody else on the assembly line who can jump in for this person. And in the last couple of years, they've gotten very familiar with something else, which is a concept called presenteeism. So you are at work and everybody wishes you weren't at work. I think you know what I'm talking about. We all have presenteeism days. And that's a very real thing for them. And they have actually good data at this point about how that actually pans out. And on the government side, the costs are in, lots and lots of services. We have, in many of our big West Coast cities now, big homelessness problems. We have huge costs in the criminal justice system. Those are all costs that you could attribute to, untreated or undertreated mental health and addiction problems that governments have to shoulder. And then I think more recently, we've come to really understand that these problems don't just cause disability, they could also kill you. So we now understand that a person who lives with a very serious mental illness like schizophrenia might have their life expectancy reduced by as much as 25 years. So that's like growing up in a very, very poor, very developing country. We have in this country now 1 suicide about every 13 minutes. We have 1 overdose death about every 8 minutes. We have more people dying from suicides than we have from motor vehicle accidents. And last year, and some of you have read this or heard about this, more people died from opioid overdoses than all Americans that died in all the years of the Vietnam War. So these are some things that have now gotten everyone's attention. That's, I think, new and that's important. And I think at the end of the day, and I'll end up with some work we're doing with our state legislature, because I would say this is one area where you get pretty good bipartisan agreement on the fact that this is a problem and we got to do something about it. Because I really feel like, there isn't a family, and it might be we have a biased perspective, but I think it could be honestly said that there isn't a family that hasn't been touched by somebody who has a mental health or substance use problem. And if you really think about that, that affects everybody. It affects Democrats and Republicans and everybody. And I think if you make that case in the right way, you can get a fair amount of attention to this. So a little bit of epidemiology. This is from a study that's now a little over a decade old, the National Comorbidity Survey, but it's still true. So if these are all the people who are living in the US or maybe in San Diego or maybe in La Jolla with a diagnosable mental disorder, how many of them do you think will see a psychiatrist in the next 12 months? Anybody want to call out anything? How many of these mentally ill people, these are all people who have diagnosable mental health or addiction problems, how many of them will see a psychiatrist in the next 12 months? 10%. Okay, we got all the way from 5 to 18. You guys are either know my slides or you're already super smart. 12%, 1 out of 10. All right, so you might say, all right, there's a lot more than psychiatrists. There's psychologists, there's social worker, there's pastoral counselor. There's lots of people who make it their business to treat somebody with a mental health condition. If you took anybody who has any training whatsoever to help somebody with a mental illness, including pastoral counselors, and you say, how many of all the people who are living who will have at least one contact, one visit with somebody that broadly defined in the next 12 months? What do you think? You guys are already looking ahead. Look at this. 1 out of 5. So what if I told you, I just told you that this set of problems causes about 20 times, maybe 15 to 20 times more disability than cancer. What if I had to say that in the next 12 months, 1 out of 10 people living in San Diego with cancer will get to see a doctor who has any training at all in taking care of people with cancer? We'd find that totally unacceptable, right? That's kind of where we are in mental health. So I think that's important to understand. There's some good news, and this is a big change from 30 years ago when I got into this business. 40% of people surveyed in these epidemiologic studies will say, over the last year, somebody in primary care did something to help me with a mental health or addiction problem. So I think that's good news. That's the glasses half full, and I'm a glasses half full kind of person. So I spend a lot of my time thinking about, those primary care providers who are stepping up to help some of the patients that we're not seeing in specialty mental health care. What is it that they need for, them to be a little bit more effective with this? But here's the bad news. 6 out of 10 people living with a mental disorder will say, I had absolutely nothing, not a single visit with anybody, not even a primary care doctor. So this is kind of tough, right? And this has actually been pretty much unchanged. Every 10 or 15 years, the federal government spends a lot of money on one of these, community-based epidemiologic studies. The ECA study was maybe the first big one. Access to care, use of specialty care has not improved a heck of a lot, over the last couple of decades. So a few more factoids. One of the reasons this is tough is for those of us who are psychiatrists, we're kind of unique in that half of us are kind of operating outside the insurance-based healthcare system. Half of us are have cash-only private practices, and there tend to be very small practices. And when I go to our state government and I say, I'd like to have some more money to train some more psychiatrists, they say, we give you more money, you're going to crank out a few more people who are going to go into cash-only practice. They do absolutely nothing for the state of Washington, for the public health. They'll see a handful of people. It's a complete waste of money. And I'm not saying this to make anybody here feel good or bad, but it is what it is. And even with insurance, and this is data from a cute little study that was done, was sort of a secret shopper study that they did in 4 cities in the United States, Houston, Chicago, and I forgot the other 2, where they called up psychiatrist offices and they said, I'm a person with good commercial health insurance, I have depression, can I come and see you? The vast majority of people didn't return the call. The people who did return the call, the most common answer was, I don't take new patients. And these are folks who do take insurance. And when people did give somebody an appointment, it took about 25 days to the first appointment. So that's tough access if you're struggling with a really serious problem. Our colleagues in primary care know this really well. The third bullet on this is from a big study now about 10 years ago, where they surveyed over 10,000 primary care providers in 60 US communities about access to specialty care. And what they said is, you know, psychiatry is rock bottom. 2/3 of these doctors said, you know, if I need help for a mental health problem for one of my patients, I'm basically out of luck. Maybe the worst statistics are on people who live with addiction problems. About 1 in 10 Americans who have a diagnosable addiction problem, you know, will see any kind of a specialist in the next 12 months. So this is, I think, my only cartoon. It says we couldn't get a psychiatrist, but perhaps you'd like to talk about your skin. Dr. Perry here is a dermatologist. So I showed this slide in one of my presentations in a primary care doctor's office in our neighborhood clinics. And there was a lunch talk, and there was a bunch of PCPs eating lunch, and I was telling them about why they should have a psychiatrist in the office. And the medical director of this clinic said, hey, not so fast, she said, you know. We got a dermatologist here in the clinic. We love this man. Our patients love this man. They said, you know, and when you're looking good, you're feeling good. Maybe it's actually pretty good for people's mental health. And I said, we'd like to have a couple more of him. And I said, and nobody ever asked us for a psychiatrist. So that was something I had to really take. And there was an older internist sitting in the back of the room, and he said, yep, he's going to look good going down. So I hope I didn't offend anybody too much. But this is a huge challenge. So now I'm going to show you some data. This is data from our academic healthcare system. We have, over the last couple of years, organized ourselves into what's called an accountable care organization. So that means we're not a sort of traditional HMO, but we make contracts for healthcare with large area employers. So Boeing, for example, we serve as an accountable care organization for the Boeing Corporation. And that has meant that we've gone from a pretty open system to a system that has to really understand the patient population it serves. So there is about 240,000 patients that live in the Seattle area that are empaneled with one of our primary care physicians. If you look at those 240,000 patients, in the last year, about 35,000 of them had one or more visits with their primary care provider in our healthcare system where the visit diagnosis was depression. So that's a pretty good percentage, right? And now you might say, okay, how many of those folks do we see in psychiatry? Turns out it's a really tiny number. The vast majority, even in our healthcare system, and we have 300 faculty, clinical active faculty, even with that many specialists, the vast majority of our depressed patients in our healthcare systems are not touched by psychiatry. 85% managed in primary care alone, a couple thousand managed by our collaborative care program that I'll talk a little bit more about, a very small number managed in our outpatient clinic, and a handful you know, seen on one of our inpatient services. And we have lots of specialty care. We're not a system that has no specialty care. So this is true. The vast majority of mental health, common mental disorders really are managed in primary care. And these guys have a lot of challenges. You know, they are pressed for time. You know, they have much shorter visits than we do. They're often double booked. Lots of other competing demands, lots of expectations on them. Every specialist under the sun comes to our primary care colleagues and says, hey, if you just did this one thing that I care about, you know, the world would be much better. And they're like, get in line. You know, you're like number 15. The urologist was just by, and he said, we should screen everybody for this, you know, and somebody else was by, and they said, we should screen for that. And I got 15 minutes to try to address what this patient came here for, which is none of those things. So that's what these guys are up against. The other thing they will say is if you get to know them and if you listen to them, they'll say, yeah, you want me to now do all this mental health work. What's going to happen when somebody's really sick, somebody is suicidal? You guys don't have my back. And so a lot of what I've thought about over the last 2 decades is what does it mean for us to say to them, we have your back? If you're going to be out there looking for mental illness and doing something about it. We'll be there for you, you know, to have your back. What does it actually mean? How do you really operationalize that? Okay, I lied. I have one other cartoon. All right. So when you look at what happens in primary care, and you're going to like this because this is your publication, right? This is a wonderful publication in JAGS that has a title called The 2-Minute Mental Health Visit or something like that, right? And it basically is a beautiful a piece of work where, you know, looking at a whole bunch of encounters that people had with primary care providers. And when depression was talked about or a mental health problem was talked about, the total cumulative time of talk about that, including maybe writing a prescription for a medication, was 2 minutes. So you might say, whoa, we take 90 minutes for that, or 60 minutes, or at least 30 minutes for that. How can these guys do it in 2 minutes? But that's what they're up against, right? That's what they're working with. So the good news is we have a lot of these 2-minute mental health visits now in this country. In fact, about 30 million Americans will walk out of a primary care doctor's office in any given year with a prescription for a psychiatric medication. You'd think that's amazing, right? And the bad news is that if you follow those people, a year later, only about 1 out of 5 has gotten better. And we're not even sure if that's because they got a prescription. Sometimes you just get better with time. So that's the sort of the opportunity, I would say. What we see is when you look at that, we have a tremendous amount of what I would call clinical inertia. So people get diagnosed, they get started on something, and then nothing gets changed. We have lots of prescribing of medications in this country. That's what this cartoon is trying to say. It says, of course you feel great. These things are loaded with antidepressants. I think the US, which is a pretty tiny fraction of the total world population, we consume a little more than 50% of all psychotropics that are at least legally sold in the world. We are a country that loves to take pills. What we aren't getting very much of, at least in these primary care visits, is good psychotherapy. And I think there is pretty good evidence that for most of us, a pill won't make us change our behavior. A pill might make it easier for me to change my behavior, but I still got to do something to make change. And I think good talk therapy, good psychotherapy is really often, the tool I need to help me do that. A little bit more on access to care. This is Washington state data, but you see a map for the whole United States. We have in Washington alone 158 federally designated mental health care professional shortage areas. What does that mean? That means you're living in a place where if you need a mental health professional, there isn't one. Not a psychiatrist, not a psychologist, not a clinical social worker. The estimate in our state is we have about 7 million people in the state of Washington, and there is 4.5 million people who live in areas where they essentially have no access to psychiatry, for example. And that estimate, this federal estimate, says we'd need another 200 psychiatrists if we wanted to, provide minimum coverage. This is another way to look at it, a little bit more granular. We have 17 counties in the state of Washington, 17 out of 39 that don't have a single psychiatrist. It turns out they also don't have a psychologist or a clinical social worker. So these are rural sites with really no access to specialty mental health care. So not all that different from places in the world where you don't have mental health specialists. So people have woken up to this. So this is interesting. So this is data from Meritt Hawkins. Meritt Hawkins is one of the largest physician recruitment companies in the United States. Every year they put out a survey about what are people asking us for. So 10 years ago, psychiatry was near the bottom of the kinds of things that these companies were asked to help find. In 2017, it was number 2, right after family medicine. So all of a sudden, psychiatrists are in tremendous demand. And I see this, you probably see this here in San Diego. I am really challenged to recruit psychiatrists at this point. There just aren't enough of them. Now, you might say, maybe psychiatry is a lousy thing. Nobody wants to do it. It turns out, actually, people like being psychiatrists. This is a survey done a couple years ago that basically said which young physicians would choose the same specialty again. And you can see actually psychiatry comes out near the top or at the top. So people like being psychiatrists. If you look at it from a purely economic perspective, you might say maybe psychiatrists are really well paid. Well, not so much. You know, we used to be down here. Now we're moved up a couple of ranks. We're not up here with the surgeons and medical subspecialists, but you know, this is not bad. You know, we've seen some pretty dramatic salary increases, and some of the folks in this room have sweated this. I can guarantee you over the last couple of years, because we're now having to compete with lots of people who are willing to pay a fair amount of money for a clinically trained psychiatrist. And then I want to talk a little bit about what is it that we do when we have a psychiatrist. So this is a little weird, but I'll see if I can talk about it. You know, they're saying we'd need another 192 psychiatrists in the state of Washington. So this is something, a little exercise we did in a work in progress lunch meeting, a research lunch meeting in our group a couple of years ago. And what we basically said is, we said, what do psychiatrists like to do? What are we trained to do? We train to do something we call a 50-minute hour. So the patient comes in, you meet them, you do an assessment, you try to make a treatment plan, and then you try to, you try to have 10 minutes in between that and your next patient. Maybe you'll do a little charting, maybe you go to the bathroom, have a cup of coffee, then you do another 50-minute hour. And so we said, if we took all the practicing psychiatrists that we have in this country, and we're going to make the assumption that 3% of the US population would benefit from having a psychiatric visit once a month. That's assumption. It might actually be a pretty conservative assumption. We have a lot more people who are struggling with mental health or substance use needs. And everybody is seeing patients 35 hours a week, pure patient care, no administrative time, nothing else. That's all. These are some pretty, probably unrealistic assumptions. But let's just say, how much could we actually produce? So if we took those psychiatrists and you divided 3% of the population into that number, into all those hours you have available, how much time would a psychiatrist, if you have a mental illness, be able to give you once a month? Turns out, if you're living in an urban area in the United States, it's 6 minutes. If you're in the rural United States, it's 1.5 minutes. So that 50-minute hour doesn't scale very well. We're never going to have enough psychiatrists to give 3% of the US population a 50-minute hour once a month. So that model is really cool. And I'm not saying you shouldn't learn how to do good 50-minute hours. That's a pretty foundational thing for us to be able to do that well, but it's not going to be a population health solution. We're going to have to think about other ways to try to address unmet needs, or we have to learn how to talk a lot faster, but we're not all that good here on the West Coast. You have to go to the Northeast. They can do that a lot faster. All right, so what do we do? So far, all I've done is I've told you about all kinds of woes and problems and inadequacies. So what do we do to try to close this huge gap that we have between the need and what we actually have available to take care of people? So a couple of thoughts, and I'll share a couple of examples on each of these. So we definitely need to train more people in the mental health business, not just psychiatrists. I'll train anybody who's willing to help somebody with a mental health or addiction problem. So in our place, we train psychiatrists, psychologists, lots of medical students. We train nurse practitioners, physician assistants. We have a program now for medical assistants that work in primary care doctor's office, teaching them how to do basic behavioral health care. We have a big peer training program. So I'll train anybody who's willing to say, I'm going to help somebody with a mental health problem. And training is one thing, retaining is another challenge. So doctors don't tend to drop out of what they do. We're valued enough, we're paid enough, and we put enough hours in, so we're not going to get out of the business. But the vast majority of providers in the mental health field are master's trained or bachelor's trained people who are working, for pretty low pay with some very, very difficult patients. And the retention problems in those fields are enormous. It's a little bit like, public school teachers, people burn out. They do that for 8 or 10 years and they're like, I can't do this forever. So we have actually a huge retention problem. And I think a lot now about what do we do to retain people who've made the investment to try to work in this field. I think the other thing we have to do is in the category of not working harder, but we need to think differently. We need to work smarter. We need to say, those of us who do have mental health skills, how do we leverage those skills a little bit better? And I'll give a couple of examples. The first one is, what about all those primary care doctors who have said, I'm willing to help somebody if you have my back? What are all the ways in which we can partner with people in primary care or in other community-based settings where there is an opportunity to help a person who has a mental health or addiction problem? The second opportunity is what about using technology? So if you think about it, you know, we're probably sort of the industry that has been touched at least by technology. I mean, the stuff we're doing today is stuff that I learned 30 years ago. Nothing has changed. It's kind of interesting. So, but with one of these, I could give you a 50-minute hour anywhere in the world that has access to the internet. I could give you a chat. I could do lots of things with something like simple as this. So, and we knew this a while ago. So when I went to the University of Washington as a fellow after finishing my residency in the early 1990s, I actually had a Tuesday afternoon clinic. And in that clinic, I saw psychiatric patients, and it was just like any outpatient clinic, except for this clinic was in a little town called Driggs, Idaho. That's one state over. That's a plane ride away. I was in a little family practice, and we were doing telehealth care. You know, I saw patients there. When I got done seeing the patients, we were in that primary care practice. I said, can you call in the doctor? And we had a really great three-way conversation between the primary care doctor and the patient and myself, and we were able to do pretty good care. Now that's, you know, back then this was really wild that you could do, you know, psychiatric care, you know, 2 states away. Today, that's pretty commonplace. So we have lots of ways of using technology to reach patients to make it easier. So that person who is an engineer or a machinist at Boeing, you know, they used to have to take a day off from work to come and see one of us for 30 minutes or 60 minutes. Now what Boeing is saying, do I really have to take a day off from work, you know, to see you for a half hour? What about one of these? Could I just take a half hour off from work and have the same session using telehealth care? And that's in fact what we're doing now. So we still have a lot of care that is very provider-centered, very provider-friendly, but not very patient-friendly. And I think we're going to be challenged in a pretty serious way over the next decade to think about that. So we have companies in Seattle like Amazon and Boeing and technology companies, and they're saying, you got to be kidding. I got to take a day off from work, you know, and travel. And, you know, sit in your waiting room and then talk to you for 30 minutes. Let's find a faster, smarter way to try to do that. So that's not fancy technology, just this really simple technology, right? The other thing, if we think about it from a population health way, a lot of the work we do in mental health, it's pretty far downstream. So, you know, by the time somebody gets admitted you know, in a psychotic state on a gurney in our county hospital emergency department, that's pretty far downstream. So that's sort of, in my mind, the mental health equivalent of a stage 4 cancer. And when I was in medical school, I was in the South, we saw lots of people who would first present with a stage 4 cancer. You know, they came in from the rural South. I was at Vanderbilt with these horribly disseminated, terrible stage 4 cancer. People were afraid of cancer. They didn't want to use the C word. It was pretty highly stigmatized. And what have we done in cancer? We said, that's not okay to have a stage 4. Could we prevent cancer? Could we catch it at a stage 1? And in fact, you can. Not always, but often you can. And so my question is, what is the stage 1 equivalent, you know, in a mental illness? And so how do we move things further upstream? So the furthest upstream, I think, that we can reliably go in the mental health business is not to wait until you're an adult with a mental illness or even an adolescent with a mental illness. We have invested pretty heavily in the last couple of years in our place in a concept called perinatal mental health care. So what does that mean? How can you take care of somebody who's not even born yet? That's exactly what I'm trying to do. I'm saying the best I can do is to try to provide you mental health care before you're even born. What does that mean? So we have about 90,000 births in the state of Washington every year. Exactly 45,000 of them are covered by our state Medicaid plan. And we would all pretty easily agree there's probably about 1,000 of these births that are really a high-risk situation. So you have a mom who has an addiction problem, who has struggling with a serious mental health problem. You have a domestic violence situation. You have something that's really high risk. And now you have a baby that spent 9 months in utero, you know, with a tremendous amount of stress hormones. And that kid is coming out with a differently wired brain, with a different brain. And now you have a kid that's a really fussy baby with a mom who's really stressed out and all that. really powerful stuff that we know that needs to happen called attachment isn't going to go very well. And so now you have a child that's probably 5 or 6 times more likely to develop a mental illness, when they're an adolescent. And 25 years ago, I was doing work at the World Health Organization, and the Director General at WHO at the time was a woman named Gro Brundtland. She was a family physician. She was also a 2 times former Norwegian Prime Minister. She was a pretty tough lady. And she said to me, I was pretty green and pretty young, and she said to me, we got no mental health at WHO. If we had mental health here, what would we do with it? If I gave you $1 to spend on mental health, what would you do with it? I think she was listening for, I would take on schizophrenia or I would do something like that. And I said, I would use it to treat a mom with a depression or addiction problem during pregnancy. And she's like, what? I said, well, that's your best shot. I said, you're going to help that person as early as you possibly can. And you can fit that into a lot of the maternal and child health care programs you already have invested in. So this is where I would spend that $1 on mental health. And she said, well, why would that be the right thing to do? And I told her the story I just told you guys. So, I said 9 months, stress hormones, the baby might come out with a different hardware. Attachment isn't going to go very well. Lots of problems down the road. She goes, that's a cute story. She said, is there any science behind that? And the truth is 25 years ago, there really wasn't a heck of a lot of science behind that. But now we're 25 years later, and every one of these connections has been pretty well documented. There's lots of good science actually now that you can bring to this. And so I still think that if we took a big step back, that's maybe what we need to do, is to go way further upstream. So a little bit more data. So training mental health professionals was one of the answers I put up to closing this gap. That turns out to be a very costly and time-intensive thing. So these are all the different flavors of a mental health professional you can be in the state of Washington, and it turns out years and years and thousands of hours of training needed to produce one more mental health professional. That's not a short-term fix. That's not easy. That's not cheap. That's a lot of time and a lot of money. And so we're not easily going to train ourselves out of this, although I will take anyone's money to try to train more people. Technology, I talked a little bit about. We invested in this pretty seriously about 5 or 6 years ago. We created a program in our department called the BRIGHT Center. Stands for Behavioral Health, Behavioral Research in Technology and Engineering. It's a partnership between our department and our schools of engineering and our School of Computer Science. And it's a really, really cool group of people who get together and have written grants together to say, how do we use a piece of technology to leverage what doctors can do, what psychologists can do. The picture you have on there is an app called Focus. This is work that Dror Ben-Zeev, who is one of our schizophrenia researchers, uses, using this app to augment what a traditional case manager can do for a person with schizophrenia. Been trialed in randomized controlled trials, and you would say, how can people with that serious a mental illness, get their care from an app? It turns out they can, and it was incredibly effective to help people you could do lots of short little 1, 2, 3 minute interactions, texting with people who are in the field, that if you do that at the right time, multiple times a day, a heck of a lot more effective than bringing a person in for an in face-to-face chat with a case manager, once a week or even twice a week. So I think there's lots of interesting opportunity for us to use technology to improve what we already do. A little bit more about access. We're now in a time where the large employers are, as I said, they're getting pretty savvy about what they're purchasing for their employees. Boeing, Amazon, those are our big employers in Seattle, and they're coming to my organization and saying, you guys got lousy access to mental health care. So this is what they shared with me. They said, look, in primary care, what we expect is almost instant access now. So if we have something where somebody wants to talk to somebody within an hour, you guys can do that. We have a virtual clinic where you can log on, you can talk to a doctor or a nurse using telehealth in our primary care system within an hour. We have an urgent care program, 21 clinics in our healthcare system where you can get urgent care, and if it's during business hours, you can get seen within 2 hours. That's not an emergency department visit. That's a pretty quick visit. In fact, I use this. I log on, I go to my clinic, I say I want to see you seen in urgent care. They say you've got these 4 slots, and they text me 30 minutes before the room is available. I go straight to the room. So that's the kind of access that we have now in primary care. If you want to be seen for a regular appointment within a week, they can see me in primary care. If you want the same service in our outpatient psychiatry clinic, the wait is anywhere from 2 to 6 months. Not so hot, not super competitive. And so the challenge I'm getting now is, what's with this waiting 6 months? You still have the same number of slots to give to the same number of patients. If you make everybody wait 2, 3, 4, 6 months, half of those people are going to not show, not going to have a very effective practice. So how do we move to really almost providing the same kind of access? So one of the things we did last year, this is a project we're doing with Boeing as part of our Accountable Care Network. We're giving people just that. We're saying if you want to, Monday through Friday from 8 to 5, if you're a Boeing Accountable Care Network member of our healthcare system, you can talk to a psychiatrist by phone, by voice, and soon by chat, by text, same day. It's not a traditional 50-minute hour. It might be a very short interaction, but we'll give you a psychiatrist or a psychologist that you can talk to same day. It could be about you. It could be about one of your children, one of your dependents, and everything is fair game. And we've done lots and lots of these encounters, and they're short encounters. So people have questions about, is this the right med? Somebody prescribed this medication for me. Is this the right therapy? Help me find somebody. Is this even a mental health problem that I should be dealing with? What's the right thing to do? Lots and lots of questions. We can answer them often, very efficiently. Every once in a while, somebody is in a lot of trouble, and you don't say to them, wait for 2 to 6 months. If it's really bad, you might still have to say you have to come to the emergency department, but you're going to do something right away. So it's an interesting pilot. It's been very popular. Our psychiatrists who take call on this line actually really enjoy it. You have to sort of get them used to the idea that they're not doing a 50-minute hour. You don't have to write a long note. It doesn't have to be fully comprehensive. It's different from what you learned in your residency, but it's okay. All right. The other thing that we have done a lot of is this concept of collaborative care. So this is the having the primary care doctor's back part. So what we developed, some 20 years ago now is the idea that this primary care doctor, if I train a staff member in this primary care doctor's office, this happens to be a nurse, she could be a social worker, she could be a patient navigator. If I take the patient and the primary care doctor and I add a mental health care manager and a psychiatric consultant to this team, this is the person that has your back. We might be able to help this primary care doctor to do a lot better by things like depression, anxiety, maybe substance use disorders. So how do we do that? We train a team member in the primary care provider's office. We routinely screen for people, and if say they have depression, we'll get PHQ-9s. We teach that care manager a couple of brief evidence-based psychotherapies, because I actually think that the doctors prescribe plenty of medications, but they don't do this very well. So this is what this person's job is. They'll use behavioral activation, problem-solving treatment, brief evidence-based psychotherapies to offer that right there in the primary care doctor's office. They'll say, we can do the first session right here today if the doctor refers them. We track all these patients in a registry tool, and the role of the psychiatrist is really that of a consultant. This is the person who backs you up. This is Mark Avery, one of our faculty. He has a little camera on his computer. He's not on site in the clinic, but he's able to pull up the patient's records. He's able to use this camera to have a conversation directly with the care manager in the clinic, or even to talk with the patient. So the job of this psychiatrist is not to see all the patients, but it really is to say, when a person is not getting better, when these guys are having questions, that's when the psychiatrist steps in. We did a very large trial that was published in JAMA now over a decade ago, where we tested this in a randomized controlled trial. Almost 2,000 patients, 8 healthcare organizations. In every one of these organizations, half the patients got what we call care as usual, and the other half got this kind of enhanced care, collaborative care. And we more than doubled on average the likelihood that a person's depression showed improvement 12 months out. So this was a pretty important finding. And it got us a couple more grants, but it didn't get us a lot of attention really in the healthcare field. What got us more attention is 10 years later, we did a bit of comprehensive analysis of what happened to healthcare costs for these 2,000 patients. And the Wall Street Journal picked this up, and they basically wrote, they translated a more complex paper into a simple message, which is to say for every dollar we spent on collaborative care in our intervention group, in our RCT, we saw $6.50 in reduction in total healthcare costs over the next 4 years. And so this is how the Wall Street Journal wrote the story. And that got me a heck of a lot more attention than all the papers we've ever published in the New England Journal and in JAMA and in the British Medical Journal. So if you want to get people's attention, don't publish in those kinds of medical journals. Nobody reads them. Try to get somebody in the Wall Street Journal to write about your work. Got us a lot of attention. This was actually kind of cute because the reporter who wrote the story, you can see the headline, Mental Health Care at the Doctor's Office. This was a New York City-based reporter. And in New York City, everybody has a psychiatrist and a psychologist and a psychopharmacologist. And to her, this was a radical concept that you could just go to a primary care doctor and they could give you mental health care. So, and it was really cute the day that the story broke and this article got published. I called her and she was on a phone in a cab and she said, I don't have time to talk. I'm stuck here in a cab in Manhattan and I'm late for my psychiatrist appointment. I'm like, I'm sorry, you're so stressed out. I said, maybe you should go to a primary care doctor now. Anyway, kind of interesting. But she had a very unique healthcare experience. So we did a lot more research. There's now over 80 studies that have sort of tested this concept of collaborative care. And if you do it right, it really works much better than what we do normally. We built a program called the AIMS Center, and it doesn't do research. What it does is it really tries to help organizations that want to take this model, implement it. And so it's got tons and tons of tools that we make available for free to help people implement this model. We do like writing grants. We're part of a big academic organization. So we had a couple $1 million grant from CMMI, the Center for Medicare and Medicaid, as part of their Transforming Clinical Practice initiative. And with that grant, we just wrapped this up. We trained over 3,500 psychiatrists, a couple in every state, on how to be the psychiatric consultant in this kind of work, because this is not stuff people learn in residency for the most part. We've written a couple of books that are a little different from your scientific article. So this took us a little while to figure out how to do that because we're all sort of trained to write scientific papers. And this particular book is how do you provide as a team care for things like depression or anxiety or substance use disorders. So what does everybody do on the team? What does a nurse do? What does a doctor do? What does a psychiatrist do? What does a psychologist do? And how does it all come together so that the patient actually has a pretty good experience and they actually get well? We've taken the tool we developed for the research study, which is a sort of a registry tracking tool, and we've revised it a little bit. We now license this tool in 14 US states to a couple different healthcare systems, also a Canadian province, and people are using this tool to help track populations of patients. We have distilled out a couple of the key principles that I think are really foundational if you want to do this work well. The first one is this really has to be collaborative. This can't be everybody does their thing, nobody talks to each other. So the patient really has to feel these folks are all working together. Everybody's doing their piece, but they all are working together. They're not pushing me from one person to another. The second one, probably the most important, this notion of population-based care. So I trained in clinical medicine, and then I trained in public health. And in clinical medicine, you learn what I call the numerator. The numerator is the people who are in your doctor's office, in your waiting room. And those are the people who you know about. You give them all the attention you can. You try to do a good job. And in public health, you learn about something called the denominator. Those are all the people who have the same problem, but they're not in your waiting room. Or they came to your waiting room once and now they're gone. And if they don't come back for another appointment, they're out of sight, out of mind. But when you're doing population healthcare, you're actually becoming accountable for a whole population. So that 35,000 depressed patient number that I showed you earlier, Actually, that's now become a real thing for us because Boeing is saying to us, if you want to get paid, you're going to show us that for all these 35,000 depressed patients, you have PHQ-9 scores, and we want half of them to have a score less than 5 within 4 to 7 months after you started treatment. And if you can't do that, you're not going to get paid. And now all of a sudden, I'm like, whoa, I don't even know most of these people. They're in primary care. So now this denominator has all of a sudden become a very real thing. And I think that's probably something we'll see more of. The third principle is I think we do have to use treatments that have some evidence that they work. There is still lots and lots of care that's super well intended, but it's frankly not terribly effective. And then maybe the other really important principle is you have to treat to a target. Everybody else in medicine does this. Our colleagues in primary care, when they treat hypertension, they measure my blood pressure. When they treat diabetes, they measure my hemoglobin A1C. When we treat depression, we say, how are you feeling today? If you treated my blood pressure that way, I have high blood pressure. I've had it for 20 some years. I probably have had a stroke by now. Unfortunately, they're not saying to me, do you feel like your blood pressure is doing okay? They're measuring it. So we can measure the stuff that we treat as well. And I think if we do these things well, you can actually be accountable for a population of patients. A couple more examples of ways in which we try to apply this in our region, in our healthcare system. So we did a lot of research on this collaborative care concept, but we actually didn't start using it in our own healthcare system until about 10 years ago. And then we pretty aggressively implemented this. We now have full-on collaborative care in every one of the 20 university healthcare system affiliated primary care clinics in the Puget Sound region. This is the area around Seattle. You can walk into every one of those clinics and a couple of additional clinics at our county hospital and get pretty good on-site behavioral health services in primary care. The psychiatrists that we have working in these programs, one of the things they like is they say, boy, do I help a lot more people doing this model. These are some quotes. This is, the first one is from one of our psychiatrists, and she said, look, I am helping so many more people doing this. I can help a couple hundred people, in a day a week. I don't see all of them, but I weigh in on all of them, and if they have problems, I can see them. The second quote is actually, this is from Eric Turner, who is doing some of this work. Eric is a guy who trained here and worked here for quite a long time. And he said, what I like about it is it's not only benefiting the people I consult on, because I do all these consultations to primary care providers. These are smart doctors and they're learning. And the next time they see a patient, they'll use that skill that I gave them. So I think it has a pretty big leverage effect because you're doing a lot of teaching every time you do one of these consultations. In our own healthcare system, as I said, we're challenged now to meet these target metrics for Boeing, for a couple of other big employer purchasers. The first thing we had to do is to say, are we really that good at treating depression? So let's track some of these PHQ-9s. And we said, actually, only half the time we're actually getting the PHQ-9s. So we did a little pilot where we said, what if we more aggressively implemented some of these collaborative care principles? So we got up to nearly 80% the follow-up rate. And what we find is lots of this, what I call clinical inertia. People are on the same treatment for months and months and months. And they're a little bit better, not that much better, and we're not making change in treatment. Once we started tracking the outcomes, we realized some of these patients aren't getting better. This was a control group in a couple of clinics where we did what we were doing before. This shows you the number of patients who have depression response or remission. And this was the group where we did much more aggressive outcomes monitoring. And what I said is, if it's been 4 weeks and the patient isn't improved, you have to make a change in treatment. It could be a change in psychotherapy, it could be a change in medication, but you got to change something. Don't just sit on it. And look at what happened. We got some of these response and remission numbers way up, well above 50%. This line is here because this is the metric I have to reach to get paid. So you can see we lost a lot of money here, and now we're actually doing okay. There are other clinics who have taken this concept and tried it. The Mayo Clinic, and Mayo is a very good healthcare system, and they were feeling pretty good about themselves. They did this a couple years ago. They implemented this on a pretty large scale in their primary care clinics. And they published this paper where they said, they went back and looked at all of their PHQ-9 data, and they said before we implemented this program, the average person where we could actually document an improvement in depression, it took about 600 days. Once we implemented this program, it's 86 days. This is not an RCT, and it's not quite fair because if you measure more often, you're picking up more improvement. So I just want to be clear about that. But they became quite convinced that even a place like Mayo that has pretty darn good care could actually benefit from implementing some of these principles. My final couple of comments have to do with what do we do? We're a state medical school. What do we do in our state to try to really apply some of this knowledge and help more people get care and help the state help us help more people get care? So one of the things we've invested in, time, department dollars, resources over the last couple of years is to get much more actively partnering with our state, with our legislature on, how do we close this gap? How can we partner with them on closing this gap at a population level? So for the last 3 years running, we've held at our university campus what we call the Washington State Mental Health Summit. We invite legislators, key stakeholders, people from large employer groups, from the insurance industry to spend a day together to think about, what are all the out-of-the-box ideas that we're not already doing that we could be doing, to try to improve mental health care. This last one we did, we had over 600 people there. We talked about all kinds of interesting things. We talked about this concept of perinatal mental health. We talked about how much behavioral health care could you do in schools and how would you do it? We talked about workforce development. We talked about innovations at the interface of our mental health and our legal system. We talked a bit more because we're in a technology town in Seattle about opportunities to partner on technology. And I think a whole bunch of really cool ideas came out of that. One of the ideas came out of that is there's lots of other people in the state who could benefit from behavioral health training. And we have technologies now using televideo and other technologies where we could take existing providers and teach them the basics of good behavioral health care. So we got a couple $2 million from the state to build something called the ICTP, the Integrated Care Training Program. In this program, we go all over the state and we say anybody who's willing to learn how to do collaborative care, integrated care, we'll teach it to you. When we started this program in July of 2015, we had trained people in King County and Spokane. Those are our two biggest urban areas in the state. By 2018, we had trained providers in virtually every county in the state. We do this a lot of different ways. One of the things is we use the ECHO model, where we have a weekly psychiatry and addictions case conference where a couple of our faculty get on, with primary care providers all around the state, and the providers are presenting difficult cases. And we discuss the cases with them, and they learn about their own cases, but they're also learn about other people's cases. It's a pretty efficient way to do a fair amount of education. We engaged with our state on a pretty significant analysis on suicide rates. The Pacific Northwest, especially the Rocky Mountain states, so Montana, Idaho, Wyoming, have very, very high suicide rates. We published a paper in JAMA on a pretty sophisticated analysis of this. And then we built a training program. We said there's primary care providers all over the Pacific Northwest who don't really know even some of the basics of what you do when you have a person in the office who's at risk for suicide. So we built a 6-hour online training program that over 1,000 primary care providers have now taken. Our state created a law that mandated all physicians in the state of Washington, and now actually also all pharmacists, to take this training. It's not only this one, there's 4 or 5 other ways you can get that training, but there's now a law in the state that says you have to have basic knowledge of how to help somebody who's at risk for suicide. We took the program we have in our own healthcare system. We provide this kind of collaborative care partnership, have served over 50,000 patients in more than 100 primary care clinics around the state with this basic model. And what I have is that we have a couple of FTE psychiatry, and every one of these clinics has a psychiatrist that's based in our department that's designated to that clinic. and they get a half a day a week where they get that kind of collaborative care consultation. And we use our registry tool to track all these patients. So we can tell pretty much in every one of these clinics who are the people who are not doing well, who are the people who we really need to provide consultation to. It's a very efficient way to try to leverage a psychiatrist. A little bit more on the upstream stuff. In our county, in King County, which is the county around Seattle, we did a partnership with our public health agency. We took some money from them and we said, what if we offered good collaborative care to all of the 14 community health clinics that the county funds that take care of women during and after pregnancy. And we took 2,500 low-income moms who had depression and other mental health disorders who were peripartum, and we gave them collaborative care. This is a little data. This is from the first 600 patients, or over 700 patients. We had a little baseline group. There were about 100 women that were treated before we implemented this, and this is a survival analysis. So what it's showing you is the number of weeks that go by until about 50% of patients have a significant improvement in their depression. So what you can see is from this curve is if you wait long enough, about 70% of women will eventually get better with their depression. It took about a little over a year for half of these women to get improvement in their depression. And after we implemented this program, and the number here is not a small n, this is 600 people served in the same clinics after we implemented the program, this doesn't change. But we shift this curve way over to the left. So now it's, you know, what is it, 2-3 months until 50% of the women in this program all of a sudden have their depression improved. That's a huge difference, you know, at a population level. We've leveraged that finding to say, what about other communities? We're just doing this in Seattle. So about a year ago, we got some money from our state healthcare authority. We now have 6 perinatal psychiatrists on our faculty, and they provide to anybody taking care of a pregnant woman. Could be a midwife, could be an obstetrician, could be a family doctor, could be a psychiatrist, free consultation on how to care for somebody with a mental health or substance use problem. This operates Monday through Friday, 9 to 5. We get about 30 calls a month. About half of them are from primary care providers. Half of them are from psychiatrists who are not that comfortable with treating pregnant women. Let's say you have a, I was consulted the other day about a young woman who has, who's 17, has type 1 diabetes, has bipolar disorder, and is pregnant. That's a complex case. You know, so I'm very happy to be able to say I have a couple of experts on our faculty who really are comfortable with this. So even psychiatrists can use good advice on something like this. About a year ago, our governor sort of took a very large step in addition to running for president, which didn't last too long. But he said, we got to upgrade our mental health system. So we did a really nice partnership with our state government where we made a pretty significant investment in workforce development in behavioral health, including growing our residency program a bit more. We put in place a statewide 24/7 telepsychiatry consultation program, and we're getting ready to build a $225 million new behavioral health teaching campus and hospital on our university campus. So I feel like about a decade worth of seriously working with our state and saying, what are your needs? How do we help people in some of the rural communities in our state actually has paid off in a pretty significant way, because I think the governments that these people actually are helpful to us. They're actually doing something. You know, if we give them some real money, maybe we can make a big difference together. This is the advertisement for a psychiatry consultation line. This operates now 8 to 5, Monday through Friday. Starting in July of this year, it has to run 24/7. So I have to have a psychiatrist or a psychologist who can take a call from anywhere in the state about somebody who has a patient they have a question about. The final 2 slides are, so this is all mostly government money. And the interesting thing is, you know, you have in almost every community people who are wealthy, who have philanthropy. And this is a gift we got recently from a wonderful couple, Mike and Lynn Garvey. Created a thing called the Garvey Institute for Brain Health Solutions. This is a big private gift, $50 million. And I think the reason we got this gift is not because I sold it to them in a good way. They watched us do a lot of work trying to work with the government, and they said, what is the government not able to fund? I said, they can fund services. The government can't fund the science that we need to get to better solutions. So what we proposed is a couple of pretty, I think, compelling ideas of what would we do if we wanted to really test innovative approaches to brain health and cognitive aging. What do we do with people who have often sort of complex mixtures of physical and emotional trauma, and people with addiction problems? This is a wonderful program that we're just getting off the ground. We also partnered with UCSF and UC Berkeley, on a big gift from Sandy Weil, who's a philanthropist. That's a $106 million investment in more basic neurosciences. This is a little bit more on the applied side. This is basic neuroscience work. I think that some of these private gifts were able to happen because people saw that we were getting politicians to step up and make significant investments, and we were able to say, there are some things that the state can fund. There are some things that are really much better done, privately. So in sum, the way I think about, we are a state institution. My mission is to improve health. The mission of UW Medicine, that parent organization that I talked to you about, is to improve the health of the public. That's our mission for UW Medicine. So the mission in our psychiatry department is to do our part to improve the health of the public. And it has to be more than just seeing a handful of patients in our outpatient clinic. So, this is the way we think of it right now. So we try to say, if you need help right away, we have really good crisis services, at our county hospital. We're building a new hospital. We have statewide consultation. So even the people who can't come to our facilities, we'll be able to reach out to them. They're talking to the same providers who are operating the services in our county hospital. And we have, federal and some philanthropic funding to say, we need better access, but we also need still a lot better solutions. So hopefully all this comes together and we can do our part for improving mental health for our region. Thank you.
Jürgen, that's an inspiring talk. Probably you described 15 programs that you've developed that have a huge impact on population health in your state and beyond. And it's inspiration for us to try to absorb that and hopefully to apply that here. Questions from the audience for our speaker?
Jürgen, you began by apologizing that you're not giving a neuroscience talk. This was more innovative and inspiring than many of the neuroscience talks I've heard. One quick question. You didn't talk about your other area of expertise, which is geriatric psychiatry. So do the cost considerations and others apply equally well to older people?
Yeah, most of the data we have actually is from our work with older people, because on the healthcare cost savings, kids are pretty healthy. They don't spend a lot of money. There's a small number that are super sick. They spend a lot of money, but when you get older, there's nobody who's not spending money in healthcare. So most of the cost savings you can realize by providing good mental health care are actually with, older or otherwise medically ill population. Absolutely. So you could make the strongest argument on potential cost savings right now is probably with the Medicare population. Absolutely true.
Thank you for the talk. Really appreciate it. I like to take risks, and I have actually helped a lot of folks in a deployment setting with like 3,000 Marines, and I had to make a lot of calls like that in 5-minute, 6-minute calls and asking, what are you going to do with this guy, doc? And then we deploy him, we keep him, or we do whatever. So I'm familiar with that. I'm trying to think of this in our bigger community, and how do I do that safely with the way our law is set up? I could just easily be sitting on trial for, you talked to this guy for 5 minutes and you did what? And here they are, and now you're gonna have to do this, and then that shuts the whole thing down. So give me some insight on that.
Yeah, so I'm not a lawyer, so probably you gotta take whatever I say with a grain of salt. But I guess what I would say is this. I think when we do these short interactions, you can't pretend you did a 50-minute hour. You have to be crystal clear about what it is you did and what it is you didn't do. You know, and if somebody calls me and says, you know, I have this person and I did this, and what do you think I should do? I might ask them a few more questions, but I didn't see the patient. I didn't do an assessment. I'm probably missing something important. And I just have to be clear about what it is and what it isn't. So what I will say is, I'll write a short note after that interaction. I'll say, you know, I consulted to Dr. So-and-so. He presented me with this, and based on what I heard, I recommended X. But I didn't see the patient. I didn't do a full assessment. And you know, if that recommendation doesn't make sense to you, you know, have the person seen by me. So I think as long as you're really clear about what it is that you did, and you're not pretending you did something, you're not competing with a 50-minute hour. I think we just have to be really clear about that. The truth is, you might say, might I miss something? Absolutely would I miss something. Well, what's the alternative? The alternative is to get nothing. So, you know, me taking a good shot using my, you know, my best clinical judgment and saying, you know, here are some things that might help is probably going to reduce the risk. It's not going to increase the risk, right? If I do nothing and this doctor works on their own, or the patient has to make decisions on their own, I don't think that's going to lower the risk. I think just have to be clear about what it is that I did, right?
Yeah, couple of questions. So one of the projects that I'm doing with the large FQHC in town, we were able to, you know, create a registry for them and being able to screen 4,000 plus patients for depression and for substance use.
Mm-hmm.
And so the model we've developed, you know, it has depression screening, substance screening, and then we link them with primary care, with substance treatment therapists, as well as depression counselors. And the adherence to the depression part has been great. I mean, in fact, we've been above our target pretty significantly. But on the substance use side, it has been very poor. And so I'm wondering if what your experience has been in collaborative care and a registry model with substance use patients up in Washington.
Yeah, I think it's a great question. I think it's sort of the next frontier for collaborative care. We have certainly tried to do things like medication-assisted treatment in partnership with primary care providers. Anecdotally, I think it works pretty well, but we're actually testing it. We just got $16 million from the NIMH to do a big trial of collaborative care for people with opioid dependence. So in about 4 or 5 years, I can tell you at a pretty large scale, we're doing this in 3 states. It's a pretty big project. I can tell you how well that works. So I think that there is probably a little bit more science that is needed to figure out exactly how to do that well. There are a couple of small trials of collaborative care for people with addiction problems, but it's not anywhere near sort of the state of the science, or the knowledge we have is not anywhere near where we are with depression. So
Okay,
and then you're right on the forefront there.
And my second question is, so we have pretty extensive experience working with psych NPs, and we just started a fellowship. I think it's probably going to be the first one of its kind. But at FQHCs, the FNP provider group is quite huge, and so we've started to work with them to train them in primary mental health care type of a program.
Yeah.
And we've had some mixed results from that. And I'm wondering, from your experience, utilization of primary care providers, MD level versus FNPs, like, do you find there to be some significant difference in the way they approach things?
Yeah, I'm going to give you guys a seizure here. Sorry about that. But, I'm going to show you back a slide that I showed you. So this is interesting. So in our state, to be an advanced registered nurse practitioner, you have 4 years of undergraduate training. You can do 2 years of graduate training, and then you're out practicing with a prescription pad. This is the only specialty where there isn't some requirement for clinical training. After you get your training, you're literally graduating from school and you're practicing. And now some of these folks are very, very good, are very skilled. Oftentimes they've had years and years of undergraduate or RN nursing, psych nursing experience. They can be clinically pretty savvy. Some of them are brand new. They went through college, they went into a nurse practitioner training program, and they're out there prescribing. So it's quite variable. So I think the idea, so think about it, in psychiatry, we do 4 years of medical school, 4 years of residency, thousands of hours of experience before you're let loose with the prescribing, right? So it's not a surprise that the skill level might be a little bit different. And again, I don't think we could judge. There are some people who have tremendous skill and experience, and some have very little. So I think what you're doing makes all the sense in the world. Create a formal training program. Say to them, look, you're licensed, you're practiced, you can already bill, but what about if we give you a year or two of supervised experience? So I would like to start a program like that at our shop. And the way I would think about doing it is I would say, can we train a nurse practitioner alongside an R2 on our inpatient unit? So they would basically spend 6 months working inpatient and then 6 months working outpatient, just like one of our residents would. And at the end of that, my sense is we'll have a pretty good sense of who's really skilled enough to practice independently and who might need some more support. But it looks like you're a step ahead of us in terms of training nurse practitioners. I think it's a really important opportunity.
Hi. Thank you so much for that talk. I'm a psychology trainee at the VA, primary care mental health integration. And kind of our goal there is to provide efficient care, kind of what you're describing. And one of the barriers we come through is assessing suicidality. And the VA has kind of pretty strict guidelines in terms of having a licensed clinician do that. And it could take like 45 minutes to an hour in doing the safety plans and doing a thorough evaluation with someone who reports having suicidal ideation, and just wondering how you've handled that in kind of trying to provide more efficient care.
Yeah, I think that's great if you can afford it, but there are a lot of suicidal patients out there where we're not going to have 45 minutes to do that. So in the meantime, you do the best you can with whatever resources you have. So I wouldn't talk you out of doing a really great assessment if you have the tools, the skills, and the time to do it. I'd like to be able to do that for everybody, but it's probably hard to scale a 45-minute assessment. So in this training program that we developed for primary care providers, we try to teach them some skills on, the basics of suicide risk assessment, making a risk assessment, making a safety plan, doing things like means reduction. So talking to patients about guns, about safe gun storage, all that stuff. It's a 6-hour training, but oftentimes when you watch people do the work, they're not doing the kind of assessment that you're being asked to do in the VA. And I'm not going to argue with that. I think that, if I was suicidal, I'd like to think I deserve 45 minutes from somebody really skilled, but it's not possible, frankly, in a lot of settings that are not resourced the way you are or the VA is to do that. So you have to do the best you can. All the way in the back there.
Hi, I'm from primary care here, from family medicine, and primary care is not the same animal as it was 15 years ago. So there's been a tremendous amount of evolution, and the idea of registries is sort of ubiquitous in primary care now, clearly not out in a rural practice probably, but in an academic center. And so I guess the question I have is, does the treatment of mental health illness or behavioral health illness in a primary care setting really need to be treated any differently than the registry work we have to do in being responsible for all the diabetics and hypertensives that aren't in the office today?
No, it's exactly the same thing. So I'll tell you a very short story. The way I got to this model is I spent a couple years being the psychiatric consultant in a family medicine clinic that's part of group health now is Kaiser. And I was there on Tuesdays, and I'd see patients. They refer me patients, and I liked doing that work. There were about 11 docs in that practice. They figured out that I was, reasonably good. So they sent me their patients, and pretty quick I booked out. I had 3 months waiting list, because I was only there on Tuesdays. And the doc started saying, well, how good is this guy? You can never get anybody in. And one day, and so what happens is when you have a 3-month wait list, you get a long no-show list because 3 months is too long. So half my patients didn't show up. So I liked my Tuesdays. It was kind of fun. Had a lot of time. And one of these no-shows, there was a lady across the hall from me. She also had a no-show. And I didn't think she was one of the docs. So I said to her, what do you do? She says, I'm a diabetes nurse specialist. I said, well, what's that? She goes, well, we have 11 doctors here. and they all have patients with diabetes. And my job is I have a list called the Registry, and I have all the diabetics in the practice on there, and I make sure they get their eyes checked once a year, and they get their feet checked once a year, and we do their A1Cs twice a year. And this was 25 years ago. So I said, what's an A1C? And she looked at me like, is this guy like a real doctor? But anyway, so I said, oh, that's interesting. I said, so when it's not looking good, what do you do? She goes, oh, I work with the doctor and we try to make changes in the meds, and I give the patients nutrition counseling and so on. And I said, well, what if that still doesn't work? She goes, well, then we got this endocrinologist, and he comes once a month and he goes through my list of all the really difficult patients we have, and he makes some recommendations about what we could do differently. And I said, what if that doesn't work? She goes, well, then he takes people into the endocrinology clinic, and he has them for a while, 6 months, 8 months, 12 months, and then he sends them back to us. And I thought, wow, that's the difference between me showing up here on Tuesday, just batting out whatever they put in front of me, and something that is really chronic illness care, right? So it's exactly how this thing evolved. You're spot on. This is basically a mental health version of what we should do with any chronic illness, right? Yeah, so that's actually how this came about.
One last question here we have time for.
Wow, what a tour de force. And I commend you particularly for your foresight on perinatal mental health.
Okay.
And, but we've had a lot of resistance here. And I'm first of all want to know if you teach your residents, both in psychiatry, family medicine, and OBGYN, reproductive psychopharmacology. And we've been trying to institute sleep and light interventions that can work within a couple of weeks, and just have not been really able to integrate it into the primary care clinics, perhaps because they're just busy or the reimbursement issues, and we found much more receptivity in the community. I'm just curious how you deal with resistance.
Wow, okay. I think that's what we all do, right? We're selling people all day long. That's what healthcare providers do, right? So I think it's, as much as we were talking about that over dinner yesterday, but as much as possible, I think it's having empathy. It's understanding what they're up against. What is it that they're worried about? So I'll go back to the registry example. You know, people say, why don't primary care doctors or even specialists want registries? I'm like, what is the registry going to do? It's going to tell you that there's a bunch of people that are in your life that are actually not as much better as you thought you want. Do you want to know that? You know, we'd like for them to want to know that, but they don't want to know that. That's not making their day go better. So it's really having empathy, I think, understanding what are these folks up against? What are their fears? What do they need? And I think the more we can do that, the better we can do things. Now, a light intervention might be a lot harder than pulling out a prescription pad and saying, try these pills, right? That's how we have so many people taking pills. So you have to really think, I think, about what would it make it really easy for them to do that, right? Just the fact that it's the right thing to do doesn't mean that it makes their day go better, right? Does it make the patient's day go better? Does it make the provider's day go better? What is it really that you'd have to do to get them to say, that's it, I found a way to make this, put this into my practice, you know, where it can really work. And yeah, we do teach psychopharm in pregnancy. Like I said, I'm very fortunate because we got philanthropic support, we got some state support, we got some grant support to really sort of explore this area of perinatal mental health. And within a couple of years, I now have 6 or 7, actually I think it's 8 this year, faculty who see themselves as perinatal psychiatrists, and they have a group that meets, they engage with people in the community. They're thinking about working with nurse midwives. They're doing partnerships with the Nurse Family Partnership, you know, that operates in our county. And I think if you get a critical mass of people getting really excited about something like this, it's kind of cool to see.
Jürgen, thank you again from all of us. To show you, we do believe in primary prevention here at UCSD. I'm going to give you this hat from UC San Diego and Department of Psychiatry. And thank you again for such a wonderful, inspiring talk.